So it's my pleasure to introduce Charmaine Martin Gaspar. Charmaine has been an acute care nurse practitioner for over 20 years with specialization in neurology, neurosurgery, neurointerventional, and neurorehabilitation. She is currently working as acute care stroke nurse practitioner for Niagara Health. Charmaine's research interests have been on subarachnoid hemorrhage patients and vasospasm treatment to prevent secondary ischemic strokes, as well as hemorrhagic strokes and neurological outcomes. She has completed the development of programs such as neurointerventional, neuro level 2 ICU, and transcranial Doppler programs, in addition to nurse practitioner role development at local, provincial, and international levels. Welcome, Charmaine.
Thank you. Welcome, everybody. It is so great to actually be able to spread this talk with everybody. Now in the era of doing everything through the internet, you lose the ability to see the audience's response. So I'll do my best to keep this topic as lively as possible. So pee and poo is something that when we're talking about neurogenic bowel and bladder, becomes always a challenging conversation, not only with our colleagues, but also with our patients and families. Just for those who haven't, I want to do the Indigenous land acknowledgement, just so that everyone knows that I'm recognizing that before I start my talk. So the objectives of the talk are to discuss why is this so taboo, to outline some of the prevalence of urinary and fecal incontinence among stroke patients, review the anatomy and physiology of how we void, describe the types of urinary incontinence, outline assessments and treatments to urinary incontinence and management. And then we'll move to the bowels. We'll talk about the anatomy and physiology for that, outline the types of fecal incontinence, and how you can look at assessment and management strategies. So why is poo bad? Well, 892 million people in the world still do not have a bathroom. So that's just tells you how fortunate we are in North America. But we do have an growing homeless population who still have no access to toilets. Not all housing, as we know, when we send our patients home, have accessible washrooms. And there's also a lot of cultural taboos, especially in certain cultures. Being a multicultural society, we need to be aware of these taboos when we're dealing with different types of patients and their discharge planning, as well as how do we manage their neurogenic bowel and bladder in the hospital. So in places like Cambodia or India, they don't even put the toilets in the home as it's conceived as being dirty. It has to be on the outside of the home. Cultural practices around cleansing after we have a bowel movement or after we urinate is different in different cultures. Some do it as a dry process, which is using toilet paper. Others do it as a wet process. In certain cultures, you do not wipe with your right hand, and this becomes challenging if people have left-sided hemiparesis. We've actually made wearing a TENS kind of sexy, which I'm appalled by. But anyway, they're making a lot of money off of it, where you too could look like this woman if you wanted to spend your life in diapers, when there's so many other options above and beyond this. Not that we don't need a TENS at times, but it's not the only strategy we have out there. In certain cultures, we have the wet process, which I referred to, and that is around how do they use bidets. And if you've ever been to Europe and in other countries like Japan or Israel, they have the stationary alone bidets, or they have the spray wash type, which is on the left side of your screen, where they do a cleansing and they don't use toilet paper, or they have the ones that are in the toilet and that helps cleanse. And these are important things to know when you're planning for your patients to rehabilitate. In fact, I think, the spray one on the left should almost be in every rehabilitation and hospital setting, for it allows for a good cleanse and diminishes the risk for acquired bladder infections. So when we look at the incidence and prevalence of, sorry, I'm just moving this picture around on my screen. When you look at the incidence and prevalence of urinary incontinence and stroke, approximately 50, so 1/2 of our patients have incontinence during their acute admission. This decreases to about 20% by 6 months. But if you're that 20%, that increases your likelihood that you're going to go live in a long-term care facility. And this is a huge difference in quality of life. Women, more than men, just because of our way we're developed, have a better way of controlling urinary incontinence. So when we think about the anatomy of what goes on, back one, with our bladder, we first need to understand what happens to the bladder. So we need to know normal function. So the detrusor muscle is the muscle around the outside of the bladder wall. You can see this large muscle. I hope you can see my arrow moving around. And the ureters actually come midway down. They don't come in the top of the bladder. They come midway down in this trigon area where we have increased musculature that expands and has lots of nerve fibers that stimulate and send messages up to the brain when we have a full bladder. We have the bladder neck, the internal and the external sphincter. We have our pubic muscles and our perineal muscles that help control and tighten those sphincters. So the things that facilitate us to be able to urinate and inhibit us from urinating is really important when we think about stroke. So facilitators of the way we go ahead and we allow our bladder to empty comes through our pons and our hypothalamus and our basal ganglia region. And so if you have a problem in your midbrain at your basal ganglia and hypothalamus, or in your brainstem at a pons related to where the stroke is located, you're going to have difficulty with being able to control your bladder. And I'll talk about the frontal lobe afterwards. Then as the information goes down to the parasympathetic pelvic nerves and the somatic pudendal nerves, that allows the sphincters to open and allows the detrusor muscle to be contracted to allow the bladder to squeeze and empty. If you want to inhibit the way we like to hold our pee until we can, it's the appropriate location, we need our frontal lobes and our midbrain, as well as our sympathetic hypogastric nerves. So anybody who has a frontal head injury, a frontal stroke, may not be able to hold it, or they will hold it and not be able to empty, depending on what the pathways are working between the frontal lobes and the middle of your brain, where your basal ganglia and hypothalamus and pons are. So these are all connective wires. And when we potty train our children, when they're toddlers, we develop pathways between the pons and the hypothalamus and the basal ganglia to the frontal lobes to hold it until we get into the appropriate setting in a washroom. And then we have the visual, the auditory, and the positional sensation of knowing that it's okay for us to go to the bathroom. So we develop this pathways, and when we can't get up to a bathroom, we can't hear ourselves urinate, we can't sit up properly, all of that becomes altered. So when we look at the anatomy here, so here is your basal ganglius hypothalamus area. And when you get your detrusor muscle expanding, the bladder muscle expanding, it sends messages up through into the pons, which is your micturition center, and says, hey, my bladder is full. It sends a message then out to the frontal lobes and says, is this appropriate or not? Your visual cortex will recognize, yes, that's a bathroom or not a bathroom, which is your visual center back here. Your parietal and sensory will know that you're in a proper seated position. Then a message goes down the spinal column and goes across the parasympathetic pelvic nerves to allow the detrusor muscle to contract really tight and allow the somatic pudendal nerve to allow the sphincters to open and let the urine come out. So if you have a right hemiparesis, just imagine that your left side of your body, the bladder will be working. If you have a right hemiparesis, the right side of your bladder, just like the right arm, the right leg, will not contract and be as spontaneous. It won't relax and contract. So it's essentially the same as your arm and leg. You expect weakness on that side of the bladder wall. There we go. When we come down to the base of the spine here, and this is why people who are paraplegics have problems emptying their bladder, we come out through the, between the L2 and the S4 are all of these nerves. The parasympathetic allow you to contract and empty. The sympathetic allow you to expand and allow the detrusor muscle to relax. So when we have the physiology of voiding, so it's important we know how do we go about voiding. So the receptors in the detrusor muscle send messages up via the spinal reflex to the pons and then to the basal ganglia and then to the frontal lobe saying, am I in the appropriate place? And everybody's seen frontal strokes or frontal head injuries that will, or frontal dementia people that will have void and or have a bowel movement in the incorrect location because they don't have that wherewithal and they don't have that connection, that feedback loop that tells them I'm in the correct place. When you come in acutely with an acute frontal lobe, basal ganglia stroke, you may retain urine because there's a disruption. And that's why we always need to bladder scan. There's a disruption in that flow until it can be retrained again. So the physiology of emptying is that the message comes from the pons and the cerebral cortex to tell you to proceed, to go ahead and have empty your bladder or your bowel. The bladder neck and the external sphincters relax and that detrusor muscle contracts because there's a rise in that intravesicular pressure. So you know where I told you the uterers were coming in the back of the bladder wall? That trigon area is super sensitive and will stimulate you when you've got a certain amount of urine in your bladder, usually greater than 300, 400 mils, except for people who tend to hold their bladder a lot, like nurses. This is just a replication of the bladder getting full. The urine stimulation goes off. You can see how thin these walls are out in the bladder. And then as they contract, they can get very tight and move in. So when people leave a catheter in for a long time in the acute phase, what you're doing is making that detrusor muscle weak. It's not allowing it, just like the arm and the leg, to work. It's convenient, but it's not in the best practice because you're not allowing those muscles to continue to work. So it's basically paralyzing the muscles to get their function. If you ever done urodynamics, you'll get your first urge around 150 mils to start thinking about, okay, my bladder's getting full. There's a reflex go up through the spine. And when you get to about 400 mils, you get about a discomfort. And then that's when you will fire off. That's why when we get greater than 300 mils in the bladder, when we're doing our intermittent CAS. Now, I have to tell you that some people have trained their bladders to hold more. And those tend to be, well, I can say nurses in general, they've studied them and we're the worst for holding lots of urine. So what factors put us at risk for urinary incontinence? Age, as our bladder gets its capacity, the muscle doesn't work as well. You tend to retain urine. It doesn't empty as well. You lose sensory awareness, and that detrusor muscle becomes more unstable. If you're diabetic and you have bad diabetic neuropathy, not only with your diabetes are you wanting to pee lots because you empty more urine out, you have increased risk for not completely being able to send those messages. And we've had people who've lost function permanently that are severe diabetics. It also increases your risk for urinary tract infections because You've got sugar in your urine, you're not emptying, and it's a nice warm place for bacteria to grow. The severity and location of your stroke. If you're in the frontal lobes, pons, or hypothalamus, basal ganglia region, you're at higher risk. And I don't know how many nurses I ask and I say, well, where's their stroke? And they don't know. And if you don't know, you won't really identify the patients at highest risk. If you've already had prior urological dysfunction or other disabling diseases, that will put you at increased risk for getting urinary incontinence. So there's different types of incontinence. And so there's two main ones or three main ones that come up to play when you look at stroke. We have the urge incontinence, which I'll explain, retention with or without overflow, which means they're constantly dribbling. If you think of a teacup in a saucer, that if you keep putting the tea in the cup, it will keep dribbling over and you'll get this constant stream of dribbling urine. You'll see urine in the attends and you'll say, oh, they're voiding, but they not necessarily are. They're just overflowing. We have functional incontinence, which definitely happens when people have a stroke. They can't functionally get to the bathroom as well. Stress incontinence is a separate issue, but we need to know if the patient had this prior to the stroke, because that will play into how our treatment plan will be. And we have mixed incontinence. So urge incontinence is the primary kind that patients have more long-term in stroke. You get this loss of urine with a strong, unstoppable urge to urinate. It's usually associated with frequent urination during the day and the night. It's referred to in some literature as an overactive bladder, and it does happen quite often at 6 months out still in some of our patients. When you think about the detrusor muscle and it's got this round thing, and if one half of the muscle isn't working well, as soon as you get a bit of urine up into that bladder, it's going to fire, because the other side isn't expanding and contracting, especially in large strokes. So you get a very overactive bladder. So the pathophysiology, as I discussed, was detrusor instability. So the bladder muscle wall unstable or hyperreflexive. And it's important to know if it's firing too quickly, because the hyperreflexive patients are the ones who might be a candidate for both medications or Botox to help with that. If you have a brain, spine, or peripheral nerve damage, especially with diabetics or with paras, this becomes another problem. Contributing factors are other neurological diseases, an excessive amount of caffeine, which I think we live on in healthcare. Constipation, if your rectum is full of stool, your bladder is being pushed forward. If you have atrophic changes like postmenopausal women who need estrogen supplements to help keep their bladder muscle from thinning too much. If you have UTI, you'll want to have a lot of urge incontinence. If you're on diuretics, you'll want to pee more. And that's one of the reasons a lot of patients don't want to take their diuretics, is they don't want to have to. I always hear when they come out to clinics, oh, I didn't take my diuretic today because I didn't want to have to pee. And this was definitely an issue during COVID when people couldn't go to any bathrooms. Overflow incontinence is a different kind of urination. And actually, when you're at the bedside with the patient, you can palpate a distended bladder. You start at the belly button and you palpate down and you percuss to hear for when it's like a drum-like. And if you push on it, you can actually see urine dribbling out. These are the patients early on, especially if they're men and they have a large prostate, will be at higher risk. People who have frontal lobe strokes or midbrain strokes are at higher risk. So that's why you need to know where your stroke is, and you need to know their history. If they have problems with benign prostatic hypertrophy, if they have urethral strictures as a history, if they're diabetic and they have poor nerve control, if they have any upper motor neuron diseases, such as stroke, such as MS, such as Parkinson's, or lower motor, which is the nerves coming out from the spine out to the bladder, those can affect it as well. If you're taking a lot of anticholinergics, you can have problems with retaining. or antispasmodic meds where the muscle gets floppy. So it's an underactive detrusor muscle or an injury to the brain, pons and frontal lobe, or to the spine. So stress incontinence, and I think almost every woman who's had children can understand this one, or any man, older man who's had a prosthetic surgery, because it's a risk associated with that. You have a full bladder, you sneeze, you laugh, you do exercises, and suddenly you lose control of a small amount of urine. We should be aware of this condition when we're rehabilitating the patients, because that's already telling us that we have a weak pelvic floor. And that's where, honestly, the marketing for all of these attends is directed at, is that women can do everything. We just need to put on a diaper. So it's related to sphincter incompetency and urethral instability. So your urethra that comes down from your bladder, your pelvic muscles are not holding that tight. This happens with after prolapse from childbirth, excessive amount of caffeine, not enough water, decreased estrogen postmenopause, and sphincter weakness or damage after a prostatectomy. Functional incontinence is pretty self-explanatory. If you have a cognitive impairments, people with frontal lobe dementia are particularly at risk, because we're not getting good communication between the frontal lobe and the midbrain and the pons. They're at high risk for urinary retention. Physical impairments, obviously, if you can't get to the bathroom or can't stand at the side of the bed, then that becomes more probable. Psychological factors, and these have to do with people's concerns or upset around being able to manage their bladder or bowel in a different way. And environmental barriers. Obviously, if your bathroom is upstairs and you're downstairs and you can't do the steps, this is a definite environmental barrier. So in a pure functional incontinence, you're supposed to have normal bladder and urethral function, but oftentimes, like I said, the fifth kind of urinary incontinence is a mix. So they have urgency and functional impairment. So you look at all the things that you should be looking at that will impact that when you're doing your assessment. So how physically able are you? Can they cognitively understand and remember what I'm telling them? Is there environmental barriers? Is there psychological barriers? Is there a language barrier? And we have lots of pictures or other ways with working with the family of setting up communication boards to help with that. Is there physical restraints? I mean, that's unfortunately a reality. The bed rails, this, that, these are all restraints. We're in a hospital environment. It's strange. We don't know where everything is. We get fatigued. We don't get enough rest. If there cultural things where my left hand is weak and I'm not going to wipe myself with my right hand. I don't have a spray hose. I can't manage it because I won't touch that part. These are all parts of the things. And then, of course, as we get a larger bariatric population, just doing the physical maneuvering to get to the bathroom is another functional challenge. So what do we need to do if we're looking at incontinence management with our patients? We need to know, when did it occur? Did it have some problems with like a stress incontinence beforehand, and now it's significantly worse since the stroke? We need to be able to keep a bladder diary. How frequently do I need to go, and what times of the day? Am I going all night? Am I going mostly during the day? And these are important when we're thinking about adjusting medications, looking at our oral intake. Does it happen when I sneeze or cough? Is it associated with a strong sense of urgency? Or is it dribbling all the time, which is more of an overflow problem related to urinary retention? And what do I use, or what did I use before I came in the hospital? And now what will I need now? We need to know a little bit about their toileting patterns before. Like if a person says, I usually had to get up once a night before, that's likely not going to change now. Are they aware when their bladder is full, or are they rushing when they're already too late? Can they hold it to get to someplace? I always say to the patient, wait, can you hold it beforehand? Because if that wasn't if they couldn't do that before, then I need to be thinking about, do I need to have strategies that they would work on pelvic floor strengthening? Do they have any obstructive symptoms? And this is particularly in men. Do they have problems where they stand in front of the latrine and they hesitate and they have a low stream flow and they're dribbling urine between voids? If all of this was present, or some of this was present before, or they had frequent urinary tract infections, these are things we'd have to know in preparation for making a plan now that they've had a stroke. You need to know how many childbirths they've had. Do they have any prolapse organs? So women who have a rectocele, a vagocele, or their bladder is prolapsed backwards, need to be looking at getting pessaries in order to control that. Do they have a lot of problems with urinary tract infections? How often? And then other things that will really impact their history is, how well is their hemoglobin A1C? Do they control their sugars? Are they profoundly depressed and not engaged in the process? Because you can't make someone feel excited about a bowel and bladder retraining if they're not emotionally in that state. If they have renal diseases, we need to know that their creatinines aren't climbing, especially if they're not emptying their bladder. If they have heart failure, they're definitely going to be on diuretics, and this is going to be a challenge around being able to bladder retrain. If they had previous strokes, Parkinson's, because I remember I talked about how the basal ganglia is part of this. If they have frontal lobe dementias, or if they've had cancer, sort of their gynae, of their spine, that's impacting the way if they've had radiation treatments there. The other thing, this is why it's a multidisciplinary process. We need to know from the pharmacists and the nurses, what time is their diuretics? Do they get sedatives? Are they on anticholinergics? Are they on amitriptyline? Amitriptyline or nortriptyline can make you retain urine. And are they on a lot of opioids that would give them constipation and would be impacting the bladder? Do they have their diabetes under good control? Do they have, how much coffee do they drink in a day? Hopefully they're not drinking in the hospital or in the rehab center, but that would be important for when they go home. What is their perception about the problem, and how much do they want to fix it? If they don't want to do a lot of work to fix it, we could be trying really hard and they don't see it as a problem. So we have to figure out, well, how they feel the problem is and what they want to do about it. And then we need to know what kind of environment we're going to be sending them home to. So our physical assessment should be generally, what's their general neurological status? Like, we need to know, do they have an aphasia or a language deficit, or do they have culturally a different language? Do they have problems with manual dexterity and being able to hold something for a dry wipe or hold a urinal? Do they have gait problems? Do they have a balance issue that they could sit up on a commode chair? Is there cognition that they can attend, and their affect that they want to attend? And then we need to think about the location of the stroke. And every nurse at the bedside should know where their patients had a stroke. So if they've had a stroke in the key areas for inhibiting continence, if they have a right brain stroke, which impacts their left hand, this may lead to a cultural group of patients who cannot or will not be able to wipe themselves. And then we need to think about, would their caregiver do that for them at home? If they have neglect syndromes where they're neglecting that side of the body, that will also be a challenge. If you have a left brain stroke with right-sided weakness, you may have taken away their ability to communicate, and some people don't have a preference for right or left-sided hand wiping, and that will be something important to know. And then would they be able to use their alternate hand in a pinch? When we look at their abdomen, I don't know how many times you look at the abdomen, you want to see if there's any scars from old surgeries or any masses, but you definitely, and I don't know how good nurses are these days at learning how to palpate or percuss the bladder, but you start at your belly button and you sort of try to find the upper, by pressing in gently, the upper part of the bladder, or you can percuss going down until you hear a drum-like action. Now, some people say, I'm just going to get the bladder scanner. And if people always did that, that would be great. But sometimes people aren't doing that frequently enough, and they assume they're emptying because their attends are wet, and then they don't palpate the bladder to feel how full they are. Patients are often more restless and agitated if they have a full bladder. And we're thinking, why are they like moving around all night long? And if we bladder scan them and they're full, once we empty their bladder, they'll settle more. If they have altered sensation in their perineum region, remember, one half of the body, if it's lost sensation, it will be losing one half of the sensation of their pubic area. And if they have any pubic tenderness, the rectal area, do they have any skin breakdown? Is there any bleeding? Is there hemorrhoids? And do they have any sensation in their rectum when you just even pass toilet paper or a wipe, that they know that? And do they have any fecal impaction? Diagnostic examinations would be related to, most patients get asked when they come in under a stroke to do a basic urinalysis. So we need to know if they have an excessive amount of glucose in their urine. That will tell us that they're going to have a lot of polyuria. If they have a large bacteria count, we only do urinary cultures if they are symptomatic with a UTI, as many elderly people will still test positive for bacteria but not be symptomatic. We don't treat people unless they're symptomatic. We bladder scan and we look for anything greater than 300 mils. And you have to see them. When we did that earlier slide looking at urodynamics, once you get greater than 300 mils, your bladder will spike up to send information up to your brain to say, hey, my bladder is full. So you do a minimum of 3 post-void bladder scans. And then if it's greater than that amount, you do intermittent catheterizations. And we'll talk about that a bit more. The urinary diary is super important, and there's some really good examples. I could send that later on to people who are interested, where the patient and or the caregiver together keep a diary, and we see how much they're actually voiding and having the urge to go. Getting urodynamics used to be so much easier, and I don't know if some centers are more lucky than I am right now, but getting urodynamics on patients who you can't figure things out and whether they have a hyperreflexive detrusor muscle becomes incredibly challenging, and it's a very useful tool. For people with men in particular with the prostate enlargement, sometimes they need to have a look and do a scope to see how much, now you have a stroke and you have a large prostate, how much are we going to be able to get them to be able to empty their bladder again? Promoting adequate fluid intake. Now, I don't know, and I'm sure everybody who's online could tell you that how many patients say, I'm not going to drink because I don't want to have to pee. This actually leads to more problems with bladder infection, constipation. They get hypotensive when we sit them up, all of these things. So we have to promote them to drink, not mostly caffeinated drinks, but other ways of getting fluid in. And I always say, do most of your drinking between up till 5 o'clock. And then after that, slow right down. Because if you don't want to be up all night, then you don't have caffeine with supper. Because if you don't want to be up all night, then don't be drinking a lot in the evening and night. Otherwise, you'll never get sleep. And how do you recover? Treat any symptomatic urinary tract infections, because if they're symptomatic, it'll be hard for them to retrain. And look at any medications. And this is the important thing, to sit down with your pharmacist and say, could we adjust some of these medications, or do they need all of these anticholinergics if they're having problems with their bowel and bladder? So treatment for urinary incontinence is, and I can't stress this enough, avoid Foley catheters. We will not get a detrusor muscle to gain function. And I know I struggle with this issue a lot because it is easy to keep it in, but we're not allowing the muscle. It's actually getting weaker and weaker. And the success of developing control over your bladder gets harder. It's just like if we don't, after childbirth, rework on our pelvic floor muscles, we have a hard time not having stress incontinence. The same thing happens after stroke. If you keep a catheter in and you don't allow the muscle to expand and contract, it's like holding a muscle and tying it down to the bed. It will never get stronger. Early mobilization in toileting and getting adaptive clothing. And I know that many hospitals use the tab diapers, but if you need to eventually, and I know that when I worked in rehab, we had pull-ups so that they could actually pull it up and down like a pair of underwear to actually practice. It's harder to do it if you have tabs. Proper positioning, especially for men with prostates, treating constipation, developing a communication system, being culturally aware, and adjust your options. And I'll talk about that in a minute. And adaptable urines and equipment. So when we're in a hospital, what do? So there's these containers here that a lot of people can bring in, which can fill up full of water, and the person can relearn. You can get them on Amazon, either from the front or the back with their hand that functions to do a wet cleanse if that's what they're used to. There comes in many versions. It's called a she-pee, and it basically is a flexible urinal that attaches into an actual male urinal. And you can just, if you could sit at the side of the bed, you could end up, sorry, just 1 second. My phone is, I got to shut it off. I thought I did. Sorry. Anyways, sorry. So you can actually use this, and people can actually bridge up, put this underneath and use a urinal depending on how functional they are. This particular urinal here is actually, I know they have this on backwards right now. It should be flipped the other way. I don't know why they did that in the picture. Has probably got the softest connector, and it's a female urinal. So if the females can bridge up or to come to the side of the bed but not get to the toilet and sit, we could actually get them to use a female urinal to urinate. And these are quite helpful for people who can't get up and down to the bathroom when they get home. This is another European model that tends to work well, and people like it. So whatever is comfortable. Males are good because they can just use a regular urinal. Women in particular have to come up with more inventive strategies. They now have flushable wipes, so you don't have to try and imagine what you're going to do to cleanse if you're struggling. And or you have these bottles that you can fill up and put beside the toilet. And that way, when you're in a rush, you already have them there and you get your wet cleanse. So what are some of the medication treatments for urge incontinence? So there's the anticholinergic meds, which we've talked about, that can cause problems with urinary retention, but some of them are very helpful in low doses. So some of the ones that are well studied is ditropan, detrol, and Toviaz. They help decrease the detrusors contractions. So they don't let them, as soon as the bladder fills up a little bit and it fires off with urge incontinence, it allows that muscle to relax, being able to hold more urine so they don't have to go every hour. Vesicare, if you have a lot of muscle spasticity and pain, which you can only really tell with urodynamics, or the patient complains that when the bladder expands, they have terrible cramping pain, Vesicare helps with the spasms of the detrusor muscle. There's a newer med that has less side effects called Enablex. We don't have it in the hospital, so I don't ever get to prescribe it, but it's less confusion, which is some of the side effects of these meds. You can have increasing confusion, you can have worsening constipation. So you have to be really careful when you think about starting meds that you're actually not causing more harm. And you've done other strategies like hydration, fiber, positioning, all of that. Mirabegron has less side effects than the anticholinergic, and I find that we're tending towards that more. And then for people who have a very spastic, and rapid detrusor muscle. You can get Botox injections into that, and it gives you 3 months of not having to take all these other meds. So that's really helpful if you have a hyper-reflexive detrusor muscle. Cymbalta has also been shown in some studies to help with patients because it's an SNRI versus an SSRI, and it's a neuroreceptor inhibitor. So if you have a spastic hyperreflexive bladder, it helps decrease that receptive response. So treatment modalities, sort of the mind, the brain, and the body have to really be working together to make this work, and they have to be engaged in wanting to do it. So there's the timed voiding, where you increase the time. So every 2 hours or every 3 hours, depending on your bladder journal, how often you're peeing, you say to them, okay, now this is your time. We're going to go up, and before you're in a hurry, and we're going to get you to pee in your urinal or in the toilet, or however we're going to do that. And then you increase the amount of time until that bladder is able to maximize the time between accidents. Now, for some people who have dementia, it's the caregivers trying to prevent the problem, and they're just doing the timing to prevent problems. For people who can engage their frontal lobes and reestablish those pathways again, they are actually training their brain themselves. So question you always ask is, am I training the patient, or am I training the caregiver? And those things are important only if you know how well the frontal lobe is functioning. There's Kegel exercises, and this is an excellent video for people to know how to do them correctly. And there's also lots of other ones out on YouTube, because practicing their Kegels when they're in bed. I remember when I worked at St. Peter's, I used to say in the slow stream rehab, I tease the patients, are you Kegling? And then they, because they have to practice it. Oftentimes we do it wrong. And if you are out of the hospital, I would recommend highly that you go to a pelvic floor physiotherapist. They're really good at helping you figure this out and helping you get a stronger Kegel, especially if you had a stress incontinence on top of now an urge incontinence. So you have this mixed problem. There's all sorts of sacral neuromodulation things and all that, which comes into money and cost and being able to be figured out that. And like I said, pelvic physiotherapy is helpful. Urinary retention is, once again, like I've mentioned earlier, the detrusor muscle is kind of stuck in it because the frontal lobes aren't telling it to empty. You have an incontinent diaper all the time. This is the common thing I'm seeing the nurses not recognizing. You have to make sure that you're doing intermittent casts, and you want to keep the volume. So how frequently you do them is to keep the volume under 500 mils, because we're not trying to overextend that bladder and reflux urine up into the ureters, into the kidneys. You do a clean technique for a competent person, and for a immunocompromised, you do a sterile technique. For urinary retention, we use Bothanicol. It helps stimulate it. For people with prostates, we put them on an array of different prostate meds to help with that. And there's also, if you have a prolapsed vaginal bladder or rectal wall, we send them over to OB-GYN to get a pessary. Botox is also very helpful with this. So we don't want to diss the piss, and we want to move on now to the bowel, because I'm going to run out of time because there's so much information. So I'm going to quickly slide into fecal incontinence. So fecal incontinence is very common very early on, but still you can see it's 30% in the first 7 to 10 days after stroke, but 15% still at 3 years. So managing the bowels is a huge issue. And if you are fecally and urinary incontinence, you have a higher likelihood of going to a nursing home. It has a poor prognosis. So, and oftentimes stroke patients got prone to constipation physiologically and for clinical reasons, because they're not moving around as much. They've got delayed colonic transit time. They've got impaired mobility, dehydration because they're not drinking as much, polypharmacy, dietary things. If you're not eating a lot of fruit, vegetables, fiber, which we don't really get a lot of in the hospital, it becomes harder. And I always encourage families to bring things in. So fecal incontinence, the one that's most common is constipation with fecal overflow. So when I look at the charts outside the room and it says, oh, they're having a small amount smear, I know that if I did a rectal on them, they would have hard stool with liquid stool coming around them, especially in frontal lobe patients. So any frontal lobe dementias, frontal head injuries, frontal lobe strokes, they're not going to initiate. If you have an old spinal cord injury, if you have Parkinson's, diabetes that's been really badly controlled, or MS. So when we look at the anatomy of this, so this is coming from your cortex down, coming up from your brain. It comes down into the spine. And remember, we talked about this being in the lower lumbar region. You have your skeletal muscle that holds that you have two sphincters, your internal and your external. And then you have your parasympathetic nerves that will stimulate the rectum, the lower rectum, to contract and facilitate the poo to come out of the descending colon. If you have your sympathetic things that will control it and hold it. So if you're in a fight and flight stage and you're running to get away from something, you're not going to usually, maybe afterwards you might empty your bowels, but you'll initially hold that tight and the sphincters will hold tight. So what do we want to know about fecal incontinence? We need to know, did they have problems with their bowels before? What kinds of stuff did they take for this? If they're already taking a whole bunch of meds before and doing prune juice and all sorts of stuff, then starting off with Senecot once a day isn't going to do much of anything, or putting them on Restoralax once a day. We need to know what kind of problems. If they had problems with diverticuli, if they've had problems with celiac and things come through, then do they need Metamucil to help with bulking their stools? So all of this information is super important in making a plan. Our neurological exam is we need to know what weaknesses. Do they have sensory loss? Do they sense that their rectum area? Can they balance themselves on the commode? And do they have neglect that they're not, paying attention to that side of their body, so they won't wipe or they won't notice? If they've got cognitive impairment, and do they understand what we're saying? Can they transfer? Are they able to bridge up their legs to use a commode? Can they sit? These are all important. Can they comprehend instructions? And if not, will they follow gestures or pictures? So not everybody who's aphasic doesn't mean that they can't be rehabilitated. We need to keep in a minimum of 2 to 2.5 liters of fluid per day, which can be tough. And fiber intake, fresh fruit and vegetables are just not something I commonly see on the trays for patients. If they have dysphagia and they're not getting a good fibrous diet, that can be a problem. And if they have cultural preferences, like I said, we need to know that up front. Going to the cultural preferences, if they do have a preference for wet and we don't have a system set up like those hoses, then you ask the families to bring in those jugs with the spray things so that they can practice doing that. They're not expensive and it certainly would facilitate them managing their own bowels. So when you look at a patient, you want to visually inspect their abdomen, how distended, how hard, do they have bowel sounds? Can we palpate masses in the left lower quadrant, which is often hard stool? Do they have sensitivity in the perineal region that they're like a bad hemorrhoids? So we'd want to treat those. Do they have sphincter control? And do they have a large fecal load, which we can often either palpate or see on X-ray? The RNAO guidelines are super important. Before you start a bowel plan, you got to cleanse them out. Everybody says, well, I haven't ate much for 3 days, but you came in with a full bowel. So you have to cleanse them out. Then you need to develop a schedule. And you try to figure out what's their schedule before and what will we do now. Push fluids, increase fiber. The more exercising and up they are as they recover, the better, but that's hard early on. Privacy, man, some of these curtains in our ward rooms have a lot to be lost for privacy. Adaptive clothings, adaptive devices, and a communication system or a communication board. We need to get them more positioned upright, even if it means putting them on a bedpan and sitting them up a bit more if possible in bed. And if they're a frontal lobe stroke, we need to do rectal suppositories with rectal stimulation, at least for the first 3 days, and then every other, until we can start promoting that frontal lobe and that to initiate, because that rectal stim goes up the spine to the middle of the brain into the frontal lobes. And you have to have them in a washroom-like setting when you do this, because you're trying to give the same surroundings that they learned when they were a kid. I'm sitting on a commode chair over a bathroom. You put the water on, dripping in the bathroom. So you're trying to stimulate that same learned pathways to re-get again. You need to think about peg flakes or Restoralax, Senecot, and then there's a whole host of other things if they're profoundly constipated. But I always clean out their bowels first before I want to be successful. You need to keep accurate Bristol stool chartings, not only of the stool, how hard it is versus how soft, but the amount. And then look at some medications and review alternatives and know if they have some underlying dementia or learning disability. So I'm hoping I left, oh goodness, I got through and I left 7 minutes, which is good for questions. We can't hear you, Tina.
I'm sorry, I thought I had unmuted. Thank you, Charmaine, for all of this information. Ask people to consider either using the QR code there for some feedback. The link is also in the chat, but we've got some time for questions. Oh, here we do. We have a question from Rebecca. Any chance pelvic floor physio is paid by OHIP?
Oh my goodness, I wish, but it's not in the clinics that I've found for our patients anyway, where you know how they have the OHIP clinics, they don't have pelvic therapy there. I wish. I think we have to strongly advocate for that. And I don't know how we do that, but I think the physiotherapists as a group, we need to figure out how to make that happen, because the cost of people going into nursing homes because they can't manage their bowel and bladder, I think well outweighs the cost of having pelvic therapy. And we have to have accessible places for them to get into as well, to get up on the table for the pelvic therapy. That would be the other thing.
Okay. Yeah, so if anybody would like to add something into the chat or the Q&A, or if they'd like to unmute, you're welcome to do that as well and ask a question. Okay, here we have another question from Sarah. Who do we refer to for urodynamic testing or pessary?
So it's obstetrics gynecology for pessary. They get fitted, sized, and then that's actually covered by OHIP, which is a relief. And oftentimes people have to be first identified as having it. So either the physician, nurse practitioner, nurse might notice that there's a protrusion coming out of the vaginal area. And that would be the first place to go. And then you'd get ultrasounds to both on the bladder itself to officially look at that. And then if there's a problem, then you'd have to go to a transvaginal. We don't often jump and put the person through a transvaginal right away unless it's clearly obvious. They go to obstetrics gynecology, they get fitted, and then they change them. So it's not like you yourself have to become good at putting in your own pessary. It's all happens by OB-GYN, which is an amazing service. And it helps the elderly a lot in controlling their bowel, because they don't get as much fecal incontinence or urinary incontinence if they have everything pushed up. For urodynamics, I'll be open to anybody who can help us get enough urodynamics. In Hamilton, it was much easier to get urodynamics. But I can say out in the outlying areas, it's a huge challenge. And I think we're at a disadvantage for that. Not unless other people have suggestions.
Mm-hmm. Okay. And though, who would you refer to?
Oh, it's a urologist that specializes in it.
So a urologist.
So
okay.
My problem is enough urologists have enough other work that doing urodynamics doesn't pay enough. Let's be honest, and it just doesn't work out. I honestly wonder why it has to be a urologist, or whether we could get specialized clinics. Like we used to have an incontinence clinic at St. Joe's out at in the East End in Hamilton. And I know that there was a nurse practitioner there who would also do urodynamics under the guidance of a urologist, basically to read the report. And it was amazing, but we don't have enough of these services available for our patients.
Mm-hmm. Okay, so we just have a couple of minutes left. If anybody does have a question, please feel free to type it in or to unmute. Yeah. So one of the things I have added into the chat is a registration link for our next Stroke 101 webinar, which is coming up on November the 8th, and it's about maximizing communication. Okay. Okay. Well, we'll just give people another minute or so to add any questions, but do want to thank you very much, Charmaine, and let all of our participants know that they will receive an email tomorrow with a recording of the webinar and a link to the presentation slides. And if there are any questions that occur to you after this, please feel free to send it to me. My email will be in the follow-up email. Okay, so I don't see any additional questions. So,
And here I rushed
yeah,
to get it all in.
yeah. Well, no, it was fantastic. I think a lot's for us to digest.
Yeah.
No
Okay.
pun intended there, Charmaine.
Okay.
Okay.
Everybody take care. It was good to at least reach out to people again.
Yes, yes. Thank you very much, everyone, and we'll look forward to seeing you at a next webinar. Bye.
Bye.